All right, welcome everybody. Today for our PQC educational webinar series, we are going to be talking about alcohol use in pregnancy and postpartum. And today we're going to have Marge Meyer as well as Katie Leffel present with us. And before turning it over to them, I wanted to do a little bit of housekeeping. So as always with our webinars, we encourage you all to use the chat box to type in a question throughout the entire webinar. Um, you should have been muted upon entry. If you do wish to ask your question verbally during the Q&A, just unmute and ask your question. And then we have captioning, so we are doing the automatic captioning. So just go to your toolbar and find show captions. Sometimes it's hiding, so make sure you go to the more tools as well. And then, of course, we always like to ask you all to share your feedback with us. So before leaving today, please complete the evaluation. There's QR code here. You'll see it again at the end as well as a link. Okay, let's see. And since this is a joint PQC and AIM webinar, wanted to acknowledge that this webinar is partially supported by HRSA. And as such, the contents are those of our presenters and do not represent the official views of the US government. And we don't have any disclosures. All right, so at this point, going to turn it over to Katie Leffel.
Hi, everybody. I'm joining you today in a different role than I usually join these presentations. So I'm a nurse program at the coordinator at the Department of Health in the Family and Child Health Division, and I have focused on maternal mortality and perinatal substance use topics. And I generally join in that context of a content expert. But today I'm coming to you to talk about my lived experience because I think it's something that is really pertinent to this conversation today. And I feel like it's a perspective that we don't often see when we have folks with lived experience join us. So I'm going to share my experience today, and which is that I have three daughters. I have had three pregnancies, and they're all pretty far spaced apart. I have a 24-year-old, a 20-year-old, and a 9-year-old, and I'm also an alcoholic in recovery. And so when I think about my experience and what I want to share with you all today, it's about my experience being pregnant and the way that my disease progressed over those years. And I would say 24 years ago, when I got pregnant with my first daughter, um, that my relationship with alcohol was pretty mild. It didn't really impact my life very much. I had a great time, great pregnancy, no issues stopping drinking alcohol. When I don't even remember if I was screened for alcohol use during pregnancy, probably was. But it wasn't an issue. Postpartum wasn't an issue. I'm very much of a, typical social drinker. And then 5 years later, I got pregnant with my second daughter, and pretty similar experience. But at that point, my life was um, it was not very chaotic life. I was able to stay home for part time, and it felt very manageable. And then in between my second and my third child, there's a 10-year gap. And in that 10-year gap, I went to nursing school, became a nurse, um, sold a business that I owned, and had a very intense work life and had two children at home. And my relationship with alcohol really changed in that 10 years. And it definitely became a coping mechanism for me. But I managed my life perfectly well. Didn't even think it was an issue particularly. Um, but by the time I went in for my third pregnancy, I knew it was an issue and I was struggling to manage it. And on my own, not very successfully, I was screened and wasn't honest. And but managed to not drink during pregnancy was something that I could do, and it felt okay. And then my experience postpartum was very intense. I went back to a full-time job too soon and didn't have the resources or even know about the resources. Hadn't disclosed use, my pre-pregnancy use to my provider, so I couldn't ask for help. And it was incredibly stressful, that postpartum experience for me. Struggled with breastfeeding, even though I was a lactation consultant, and began what ended up as a years long struggle to manage my alcohol use with parenting, and it was really hard. And I'm now in recovery, and I'm pretty solid in recovery, and I feel very happy about that. And I'll talk about a little more detail about the screening experiences that I had and what I thought would have been helpful. But the reason why I'm sharing my story with you today is because we see our maternal mortality data and we see our PRAMS data, and we see drinking during pregnancy in our PRAMS data year after year after year. And when I have conversations with partners, they expressed a sort of opinion, or maybe we say bias here, around who is it that's drinking during pregnancy and why they're drinking during pregnancy. And what I hear a lot is, oh, it's probably just a couple drinks, like I don't think that's really an issue in Vermont. When, in my heart, I'm thinking what my experience was and the struggle that I had. And I know that it's more than that for many women. And we just don't hear those stories when we talk about it. And so when when we look at the PRAMS data that we have around substance use during pregnancy and the alcohol use, what we see it reported, but anonymously by women in our state, is that the women that report the highest rates of drinking during pregnancy are college educated, private insured, and the older moms. And to me, when I hear this data, I'm thinking, yeah, that resonates with me. I understand exactly who those women are. And that demographic that I just described is also the ones that report the lowest rates of counseling during pregnancy against alcohol use. And I just think that that is something that we need to understand for ourselves and address when we talk about the universal screening and the universal connection to supports that Marge is going to talk about. And that we need to do a better job of putting our assumptions aside and just treating everybody as somebody who might be hiding an alcohol use disorder, and or battling the stigma around it, because it is intense. And we have a project called Recovering Loudly, which details some of the stories in an effort to get at some of that stigma and bias around mothers who struggle with substance use. Um, and part of the reason why I'm coming here today to talk to you guys is because I really respect the women that were told their stories and have them available publicly, and realize that my story adds a piece to that puzzle when we talk about stigma and bias and what the experiences of perinatal substance use are. So the piece that I really want to emphasize here is that screening during pregnancy is great, but we really need to look at pre-pregnancy use when we talk about it, and we need to make sure that we're connecting for postpartum resumption of use, because that is a really key point in the struggle, because many women are able to cut back or eliminate alcohol use during pregnancy, but if it's truly an issue, it comes right back. And so we really need to be planning for that. So I'm going to turn it over to Marge, but I will talk about screening and connection to resources later on.
So, Katie, thank you so much. I know I'm not alone by feeling honored with sharing. It's such a hard thing, and you touched on so many things that we've talked about in our webinar series about substance use. That is difficulty in the initial screen. Of being honest, I recognize that as a challenge for a lot of people, and remembering to be open through the entire pregnancy. If you feel someone wants to talk that way, but more in many ways, more importantly, there we do, I believe, have a lot of substance use that gets curtailed during pregnancy, mostly successfully. And so if we even have a hint of anything in pregnancy, this issue of postpartum, and increasingly, I feel like our pregnancy webinars are about postpartum care, and this is similar in that regard. And tobacco follows the exact same trajectory in terms of quitting. And a lot of times we're like, yeah, great, you quit. But we really, really have to dig down into what happens after delivery, because it's a relatively short period of time. So anyway, so I really, really appreciate your perspective, of course, and of course your expertise. So why are we talking about alcohol use in pregnancy? It really, again, so it is so hard to talk about people who are using alcohol in pregnancy, because in some ways it's even more stigmatized. I cannot tell you the number of people that when I talk to them about their opioid use disorder and I ask them if they're drinking, they're like, oh no, I would never drink during pregnancy. There is a unique stigma around alcohol, number one. But number two, people are more likely to tell you what they're doing before pregnancy if they've stopped. And that is a great time then to assess where they are, where their drinking habits are in the big picture. Because I'll show you the data on resumption postpartum. So next slide, please. So this is a very recent paper that highlighted drinking, especially in young women. And drinking in young women, especially from 18 to 25, actually surpassed male drinking patterns in the last view. And there are all kinds of reasons about this. I'll be very curious to see what the next series looks like, because apparently the whole no alcohol craze is the whole no alcohol thing is colliding with the edible and other drugs things. So they're like, oh, they're not drinking as much, but they're using a ton of edible. And it's like, I think it's going to be different and interesting. Hopefully they'll ask all the right questions at the same time. But as you can see, it's still, fairly significant, around in reproductive age range, somewhere between, 25 and 30% of women do drink. Next slide, please. And it's not uncommon, just as with everybody else, that for our pregnant Vermonters to drink during pregnancy. And patients that drink during pregnancy, even that quit, are at higher risk for return to pre-pregnancy use postpartum. And so it makes pregnancy a particularly good time to screen for a high risk behaviors, people that would fall right in that little window of intervention for discussion and interventions. So 70% of people report drinking in the months before getting pregnant, which is obviously higher than the general population. And 18% of those report binge drinking. So alcohol use is pretty high. Vermonters under 25 are more likely to binge drink than older people. And we do an okay job telling people not to drink during pregnancy. 82% of people heard that discussion. But about 12% of them still drink during their pregnancy. And again, as Katie pointed out, this demographic of private health insurance and higher education, they are significantly more likely to drink during pregnancy. So here you can see the purple line is binge drinking before pregnancy, and the blue line is alcohol use during pregnancy. And it is remarkable that it's as high as 10 to 12%. Next slide, please. And Vermont is a leader in this, not necessarily a good way. It's been true in 2007, and then it's true And the one is drinking before pregnancy on the left, and on the right is drinking during pregnancy, where we were actually number one in the country with at about 12%. Next slide, please. So the second reason that we're talking about is because most maternal deaths occur postpartum, and most of them include multiple substances, and alcohol is frequently one of those substances. Next slide, please. So this is just the timing and causes of maternal deaths, just to remind people, is that about a quarter of patients, their pregnancy-associated deaths were during pregnancy or the date of delivery. Just about 15% were within the 42 days. That's the time we think about the classic peripartum mortality, but well over half occur after that 42-day mark. And as I have mentioned before, women are kind of under nobody's care at that point. They'll have seen people in pregnancy very, very intensively. And after like 4 to 6 weeks, that care team that it's like been like totally in their face for all of those months literally like drops away. And many people do not have a primary care person. And besides, who sees their primary care person? Not that often. I just saw mine for the first time in quite a number of years. So it's then they're always just going to the pediatrician's office, but they're not necessarily thinking about themselves. And the pediatricians do actually an awesome job really trying to understand the family, but their bandwidth is such that a lot of things might slip through and contribute to this death rate within the first year postpartum. Next slide, please. So the top factors that contribute to preventable pregnancy-related deaths, this actually was not from our data. This came from Washington State, which actually is a state that's, while larger, is quite similar to ours, with some big centers, but a lot of rural area. But I think it's, again, this lack of continuity and care coordination was virtually uniform in each death. And it just speaks to how people are just disappear from the system. Certainly lack of access, and then there are the usual quality of care and poor communication, but this difficulty in handoff, our ability to hand off from postpartum to whatever else is very, very limited, and continues to be a place that we can improve our outcomes. Next slide, please. So the third reason is that in 2026, the MMRP panel, that's the Maternal Mortality Review Panel, recommended include enhanced screening and treatment for alcohol use disorder. So I wanted to make sure, we all wanted to make sure that we covered that. Next slide, please. So substance use does remain a key driver of maternal mortality in Vermont, and that includes alcohol use. So just so you guys know, these are our recommendations from the last MMRP, was that we do feel that all birthing hospitals should incorporate our AIM safety bundles, and people have been very, very engaged in that. It's been really quite rewarding. To provide ongoing clinical and community-based perinatal education on alcohol use disorder. This is what we're trying to do today, not just during pregnancy, but also postpartum. To provide education and training resources to increase the understanding of perinatal providers and the use of naltrexone. We're going to talk about treatment for alcohol use disorder and other medications to prevent return to use for people that have alcohol use disorder. To provide training on stigma and bias for clinical and community-based providers on substance misuse in the preconception through the postpartum period, with a special focus on return to use in the postpartum period. And we've done quite a lot of work on stigma and bias. I still think we can probably do better. And again, these warm handoffs, which I think are a challenge, because to hand somebody off, you have to have somebody receiving them, and that remains a gap. So next slide, please. So screening at the first prenatal visits. The goal of screening is, I think that in this setting, oftentimes we're like, do you do this? No, done. But I do believe that when we think about substance use training, we actually have to like retrain ourselves about screening for substance use in pregnancy, not to just think about what are you doing today or even during your pregnancy, but with the lens of what you tell me today about what you did and what you stopped is actually a risk factor for what might happen in that very vulnerable next year. And I know that I haven't really thought about screening that way. I know, having listened to Katie's story, I've actually thought about it much more. And I haven't really thought about any of the screenings that we do through the lens of, how can I help you in the postpartum period moving forward, even if it doesn't feel like it's super active right now? And that's going to be true for pretty much everything. Interestingly, of all the people I do it, actually, we do a pretty good job with our diabetics. But except for that, I don't think we help anybody. So to review alcohol use in pregnancy, which I think we do okay with, and pre-pregnancy not as well, and risking postpartum, which I would say not at all. And that's because pregnant people resume prior alcohol use postpartum. And identification of at-risk drinking, even if it's not in pregnancy, can set the tone for attention to at-risk drinking postpartum. Even if you can't hand somebody off, just having the conversation postpartum, I cannot believe would not be impactful. Next slide, please. So there are a lot of different ones, but by far the easiest one is the Audit C. I think that's what most people use anyway. There's actually an awesome online calculator. I have a link to it. Oh yeah, it's right there on this slide. But if you honestly just Google it, you can find a translator. You can find a calculator online. Not very many questions, just 3 of them. There's a scoring system. You use the calculator. You figure out what they're, in terms of what their risk scoring system is. And really what you want to identify, are these people at increasing risk, higher risk, and of course you want to understand people that may be dependent. It's always nice to have a framework of how to translate what people tell you into exactly how much alcohol, and there you have it. I think that, just 5 ounces of wine is one dose, so is one drink. So you might need to ask a few more questions, not just about how often do you have a drink. You're going to have to ask them about, what does that look like? Because if their drink looks like that big, one of those big goblets you see on TV, well, then that could be substantially more than just one drink. Next slide, please. Here, I just pulled this off the calculator to show you how somebody who really has kind of what we would consider social drinking, 2 to 4 times a month, you have a drink with alcohol. When you drink, you have 1 or 2 drinks at a time, and you do it less than once a month. I don't think we're going to find a lot of people that are at risk with with these low level things. So I don't think that you have to be worried about this being overly sensitive. And apparently this is the same tool that's used by the nurse home visiting, who of course we can't emphasize enough how important referrals are for everybody in the state. They'll screen your patients regularly as well. But I think this tool is super easy to find. It's easy and nice to have the calculator. It makes it super, super fast. Next slide, please. So this actually, I actually draw this pyramid out. Sometimes I'll print it off for people. not so much because of the how many people drink as much as you do, but just for people to know where they are, that there is a pyramid structure, and for them to think about where they are in the structure. This is kind of like peer support, just in case you're like, everybody drinks as much as I do. This is not, this is not unusual, to make sure that they kind of know where they are. And I think you're not going to see a lot of people in the red, but boy, I think we will see a lot of people in that yellow and orange categories. And I actually bring that up when I get their initial prenatal, and I admit that, before now, I never revisited it postpartum, but I think it's critical to do so. Um, so most people, 2/3 of the people are going to be in that low risk group. But I have to say I think generally the people that are in the red will come out in some other ways. It's these people in the yellow and the orange that we have an opportunity that interventions will help. Next slide, please. So this is actually the one this is the simplified one that I showed them. Just if they're in the high risk group, if they're in this risky or harmful use, or this is low risk group. And it's a great time to initiate the conversations. And again, the key is going to be flagging our charts so that you can revisit it postpartum. Next slide, please. So diagnosis. There are multiple that are diagnoses associated with alcohol use. You can have harmful use, you can have dependence, and you can have alcohol use disorder. I don't, the specifics about which of these I think is beyond the scope. This talk would have to be a lot longer. I think for me and for you guys, understanding where they are in their risk categories, identifying people that are at risk, identify people that have substance alcohol use disorder, using our standard substance use disorder framework of how it's impacting their life and their family and their relationships is really, you don't have to be much more weedy than that. Next slide, please. So interventions. This is one actually where psychosocial interventions are actually pretty good. And they're quite good for actually all of them. And they should be, and you should consider psychosocial interventions for any at-use risk behavior. Those yellow and orange criteria, those people that are right in the middle, and even include pre-pregnancy, even if they're not currently drinking. Because if you start that conversation early on and say, you might want to talk to somebody while you're not drinking, about drinking, and really just heightening this awareness about postpartum, I think may well help. I do want to talk a little bit about pharmacotherapy interventions, which you only use for alcohol use disorder. These are people that are continuing to drink during pregnancy. And I have to say that as I talk to people about really any substances, I pretty much know that if people could stop, this is true, tobacco, opioid, name it, alcohol, whatever, if they could stop, they would stop during pregnancy. I have pretty much not met anybody that did not fit that framework. So it's reasonable to talk about pharmacotherapy because some people that psychosocial therapy might be enough, but if they cannot stop during pregnancy, and alcohol being a uniquely bad teratogen is particularly important to consider pharmacotherapy. Next slide. So psychosocial interventions, this would be for all people who may benefit from any kind of intervention, and that is not just including, but I would actually add, especially at-risk people, is that if even people with alcohol use disorder, if you add psychosocial intervention, they had a greater likelihood of achieving abstinence within 3 months as opposed to not. And I want to add that is uniquely different compared to opioids, where psychosocial therapy been very iffy. The point is that it's actually particularly effective for alcohol use disorder. CBT in particular can be quite expensive, but contingency management, I would say any good licensed substance use counselor will use some form of these particular interventions. CBT, contingency management, motivated injury, coping skills training. The Cochrane review that I used also indicated this issue of 12-step facilitation, and honestly, it is very effective for many people. And if that is something that resonates with people, I would not discount their effectiveness. And I feel like in many ways, there's awesome stories. You can find podcasts and things on the internet about the guy that actually developed the 12-step program in Alcoholics Anonymous. If you have not heard anything about it, I would strongly suggest you do that because it's a great story. That is really, it just tells you how much people like to have their community. It is the original peer support. And it is much better structured than pretty much any other peer support program. So I think strongly encouraging that if it works for people. Next slide, please. From a pharmacotherapy standpoint, I bring this up because there are so many people, and I still actually hear about it, and I'll talk about why I think that is, that say you really can't use any pharmacotherapy in pregnancy. And it is because many of the societies recommend against therapy. And thankfully, my buddy Mishka Turplin, who you guys all know because he's come and talked to us a lot, wrote a lovely editorial about how kind of ridiculous that was. And honestly, we would have been in that same boat with buprenorphine if people not approached it so carefully. So the idea that you would have somebody using a teratogen, having a medication that was approved outside of pregnancy and not using it in pregnancy makes absolutely no sense. However, that be that as it may, daltesilfurium, you really should not be using that medication anymore in anybody, and definitely shouldn't be used in pregnancy. Acamprosate, people don't have as much experience with. I know I certainly don't, but it certainly can be used in pregnancy. But so can naltrexone, and we know a lot about naltrexone because of its cousin naloxone, and that can be used in pregnancy, and it's quite effective. Next slide, please. So the benefit of treating to stop alcohol use in someone who's using during pregnancy is almost always going to outweigh even any risk. And I would argue that given what we know now about naloxone, this risk would be, if not proved in a randomized trial to be safe, it has been proven to be way more safe than alcohol. Alcohol is a teratogen that has effects all the way throughout pregnancy. Remember, it's a neurodevelopmental problem target. And so this actually makes early pregnancy, I know people might be annoyed at me by hearing this, but then there's not as much neural really maturation development early on. It is a uniquely terrible thing, especially at the end. And I like to make sure I emphasize that so that people don't feel like, well, I've been drinking for the first 12 weeks of pregnancy, I may as well just keep going. And that nothing could be further from the truth. It is one of the few teratogens that actually has an effect directly on fetal development all the way through pregnancy. And that is not a common thing. Pharmacotherapy is very effective. Naloxone naltrexone has been used in pregnancy for opioid use disorder, and there are reasonable safety data. We just recommend stopping 7 to 10 days before delivery. And remember, since this is an opioid antagonist, you can just stop it. You don't have withdrawal. It's not an agonist. It's an antagonist. So you can just stop it. and you stop it because it does help with pain control. You should use shared decision making because there are not trials of naltrexone in alcohol use disorder and pregnancy. There's there are not very many case series, and I do believe that people are being treated, but they're just not publishing them in aggregate. And you can use Camprosate, but naltrexone is preferred. Next slide, please. So the dosing is basically naltrexone, 50 milligrams a day. Stop it prior to delivery. We avoid long-acting injectable because it's if you go into labor or do something all of a sudden, it's harder to stop it. There are 30 days. And for some people, they can have nausea, and you can always reassess it as needed. But if you're kind of wondering about sort of the history of what this is the reference from Mishka, and Aaron Keelty is the first author about pharmacotherapies for alcohol use disorder, because it's not clear to really any of us, frankly, why it's not more carefully embraced. Next slide, please. Discontinuation of medical, and because so many people are, maybe you shouldn't use it in pregnancy, maybe you shouldn't use naltrexone in pregnancy, maybe you'll do okay without it, they stop their medication during pregnancy. And so we have documented that discontinuation, say if they're on naltrexone, is very high, and which is fine. Except for then you might want to revisit it postpartum, but nobody does. And so people don't restart it postpartum at a time where they're more vulnerable. And given what we know about pre-pregnancy alcohol intake and the resumption after delivery, people who stop in pregnancy are very high at high risk for return to at-risk alcohol use postpartum. So the key points to share with patients is that naltrexone has minimal excretion, it's consistent with breastfeeding, and they should, especially if they were on it prior to pregnancy, they can see how they're doing, but make sure that they've got their psychotherapy that's continuing to go on. Make sure you have frank conversations about whether or not they should resume medication postpartum. Next slide, please. So I didn't want to get way into the fetal alcohol syndrome disorder weeds because it is really complicated and the diagnosis remains particularly challenging. And there's not a lot of reliability because most of maternal drinking behaviors are self-reported. There are not good biomarkers for a diagnosis of FASD. It is very infrequent that you have these diagnostic dysmorphic facial features. And people use different diagnostic systems and they disagree on the criteria. There are other outcomes that can be associated with alcohol use disorder, small babies, preeclampsia, spontaneous preterm birth. All of these cause childhood behavior issues. So it is very, very difficult. These are my two favorite references here on the effects of low and moderate alcohol consumption and binge drinking. That's a good paper. And the association between maternal alcohol consumption in early pregnancy and outcomes is another good one. And I will say that there are dose effects that are around alcohol, and there is still a lot of, honestly, uncertainty about people who drink early and then stop, about whether or not that impacts any outcomes. So I feel like we can be very reassuring in terms of people that have been drinking in early pregnancy, but stop. But I do think the importance is that they stop and that it gets addressed and after. Next slide, please. Alcohol use is actually common during lactation. Many people will remember, right? You tell people to drink a beer so that they can relax and it helps their letdown. Maybe I'm just old. Maybe I don't say that anymore. We used to tell them to drink a glass of wine after their amnios too, so they wouldn't contract so much. But especially occasional alcohol use during lactation is pretty high, and it comes back pretty much to the general population. The reported incidence of binge drinking is lower. It's down at 7 to 8%. But alcohol, again, remember, if it crosses into your brain, it's going to cross the placenta and it's going to cross into the breast milk. All of those pharmacologic properties align. So if it can cross the blood-brain barrier, it'll cross the placental barrier and it's going to cross into the milk barrier. But it is reduced. The amount of alcohol in breast milk is reduced by the passage of time. So waiting a period of time does help. So the recommendation is to wait for 2 hours after drinking to breastfeed. And if you have to breastfeed, pump and dump for the 2 hours if needed. So this came from the Breastfeeding Academy in 2023. Drinking alcohol while breastfeeding may also cause dose-dependent reductions in children's academic abilities. I found difficulty in finding data behind that. Again, I do feel like we need to not scare people, right? I think we can counsel people, but parents have enough guilt. I don't want them thinking that their kid's not in like AP English because they had a glass of wine while they were breastfeeding. So we really just have to be a little careful. I find this statement a little alarming myself, and maybe a little overdone because 80% of people are using alcohol during lactation, and I don't believe that they're the only 80% that are not like in AP English or whatever. So next slide. So with that, those are just the factual things. We'll turn it back over because Katie has so many wise things to say.
Thank you, Marge. When I see that breastfeeding slide, I just think about the hours spent calculating for me, and it's like the amount of effort that went into managing how much I could drink and how much I could breastfeed and what that looked like, and it's insane. But anyway, thank you, Marge. And I love your point about not making the emphasis be necessarily always on the impacts on the infant and the child, which is important, and I don't mean to, but I think that we reframing the conversation around the mother is really important because the guilt is real and strong for every single mom, let alone somebody using substances. And a conversation about how the mom feels about her own use and the impacts on her own life is also really important. So I'm talking a little bit about my experience with being screened because I think it's important when we talk about how to respond. So I mentioned that in my third pregnancy, I went into that pregnancy with some awareness that I had an issue with alcohol that was out of control and not healthy. Wasn't seeking any kind of support or any kind of help, although I was Googling those, alcohol screening online, taking that test over and over, and then, like kind of like, so I knew that I had some kind of issue. Anyway, so when I got screened, I was not honest because I also knew what they wanted to hear and what would avoid having to have a conversation about it. So I wasn't honest during my screenings during pregnancy, although, like I said, I did not drink during pregnancy, and that was something I managed to do. But then, and I saw a lovely midwife practice, very supportive, great practice, postpartum screened, all the stuff was fine, everything's great. And then it was in that postpartum period, I said again, my alcohol use came back ferociously, and was really a struggle from then on that became more and more of an awareness that I had an issue that I needed to deal with, but I didn't know how to deal with it because I didn't know anybody else, I thought, in my life that was in the same situation as me. And I also, had a lot of thoughts or no, I've never been, I've never had an interaction with the police. I've never gotten a DUI. I've never had, I had all these things, these reasons why it wasn't as bad as it seemed. But anyway, so I did go back to see my midwife for my just regular GYN care and was screened and this was about 2 years postpartum. And I don't remember why, but for whatever reason, I went into that visit really in a crisis, mental, like just feeling overwhelmed. And I answered honestly on the screening for the first time, maybe ever in my life, around, how many alcoholic drinks do you drink a week kind of thing. And she looked at it, and you could just see, uh, oh, a little surprise there in her face. And she just sort of responded like, not, oh, this is not what I expected. And then I burst into tears because she asked me about it. And I started to cry, and was just overwhelmed completely. And she just got more and more sort of, so you could tell that she didn't know what to do. And she just said, I think there's something, I think AA, and then booked out of the room, and never brought it up again. Any subsequent GYN appointments, which is not to say there's anything wrong with this particular human who's lovely, but that it was really clear to me that she was surprised, and my own um, idea in my head was reinforced that this is really weird and nobody else has this problem. That's a mom, that's a professional, and that uh, if she didn't know what the resources were, they were probably really hard to figure out. So uh, both of which I know now are not true. I did eventually accidentally back my way into recovery because uh, I was looking for a podcast that I thought was about parenting. It turned out to be, I accidentally listened to a podcast which was two moms in recovery, and that started my journey of listening to more and more podcasts around stories and realizing my story was not unique, and that there were resources, and that the recovery was a joyful place to be. And then from then, um, 5 years after that screening that I was honest, got into recovery. So it took me 5 years of exploring on my own, which could have been, could have been cut down had the resources been available in the moment, because that's what I experienced. And I think it's very common that you might have one chance where somebody's honest, and that's where you got to jump on it. So you got to be ready with those resources. You don't need to be the expert. You just need to have a couple of ideas in your back pocket, and manage your surprise when people burst into tears. The another data point that I wanted to share, which is just from the nurse home visiting program, they use that screening, and they do substance use screening prenatally, and also in the 2 years postpartum they do it periodically as well. And they've found in their nurse home visiting program that 26% of families at some point do reveal substance use issues. And so that's a really high number. It doesn't necessarily mean alcohol use. It doesn't necessarily mean mom. There's lots of nuance there. But what it does tell us is that it takes a sustained relationship, and it takes multiple screenings for people to feel comfortable disclosing. And so you may never get a person that feels comfortable disclosing, but you can offer them resources. You can universally make resources available in case there's something going on. And if somebody just does disclose, it's an important point to jump in there. And the other piece I really think is important from my own experience and many of the women that I know now is that medication is in screening are important pieces of it possibly, but it's really that supportive network and that emotional and mental health recovery that's really important too. So I encourage, just like we do with opioid use disorder, when the people engage with medicated treatment, there's a whole range of other resources that are available to them too, and encourage, like, you are encouraged to seek counseling, you're encouraged to go into groups. Like, those kinds of things are really, really important for sustained recovery. So I'm going to have you move to the next slide because I'm going to talk a little bit through some of the resources. So, like I said, you don't have to be an expert on alcohol use or substance use, but you just need to know how to access the resources just in case it comes up. So peer support is a hugely impactful option. It's available across the state, and every community has a peer support center, and often also every hospital has peer support specialists embedded in their emergency rooms. and sometimes they float throughout the hospital. So that is, I'm seeing Michelle Shepard's comment. Thank you. That is a resource that is available to you if in the hospital setting, and you can often have them come and talk to patients. And it's a really nice low barrier entry into supports and understanding kind of like what's available in their own regions, because these people will know what's going on in the community. AA is available virtually and in person across the state. They have a website where you can see all the meetings. It's confidential, and again, it's that network of support. Vermont Help Link is just a place you can go, and you can look at all the resources there as well. So they have a variety of kinds of resources. They also have a phone number you can call. And then there's the UVM breastfeeding and substance use handout also available as a resource. So just encourage you to have these handy wherever you are, because all of these are really low barrier access points. Next slide. And these are some provider-facing resources, to which some of which Marge went over in her presentation, but there's other kinds of resources there, and to reach out if you're looking for resources around screening and treating and supporting patients. There's a lot of information out there for us. I'm going to have you move on to the last. Well, I guess we have a few minutes at the end here for questions. Or if I missed anything, Marge and Kayla and Sam. The one thing I want to point out too is Kim Dasik's on this call, and we have developed a curriculum around perinatal substance use that's available. It's a module form. You can take it virtually, and it's available on the PQC website. And that's a great resource for understanding perinatal substance use as well.
So we do have a few minutes. So if anyone has any questions or comments, feel free to come off mute or put it in the chat. Oh, thanks, Kim. I was just going to ask if you want to drop that in there. Perfect.
I also put a link to the Recovering resource too.
And Sam just dropped the link for the evaluation for today's conversation. We have recorded this and we'll be sending this out widely because a lot of people couldn't make today's date, but we do appreciate everyone's time. Oh, go ahead, Valerie.
Yeah, I don't know. This is sort of a question comment. Recently, I had a conversation with the providers at the Johnson Health Center, and they, while they don't see a lot of pregnant people, they do a fair amount of substance use disorder treatment and peer recovery, parents in recovery, and different programs like that. And one thing that they were sharing with me was that often, as we know, with anybody really, transportation can be a major challenge. And so what often happens, and they know that sometimes, when you have them there in front of you, you might not see them again for a while. So really trying to fill in as much as you can in that visit, everything from soup to nuts. So, I mean, I can only imagine that can be challenging to try and develop that trust relationship and trying to get all those words of encouragement and referrals in a visit when you're trying to cram so much in. So, I mean, I don't know if you have any thoughts about that.
I definitely, I agree. When they're in front of you, that's the time to do it. I think, as I look through the literature, it's perhaps not thinking about pharmacotherapy soon enough. Depends on what people have been doing. If a lot of times if you're identifying it my guess is it's impacting some aspect of their life fairly seriously, and to come back to that piece of use disorder, of life impact, to think about medication as well. And to bring it, even if you don't start it right away, to bring it up as an option so people feel like there's something that's moving forward that may help them. That's all. But it's pretty clear it's underutilized compared to most, to, for example, medication for opioid use disorder.
One thing also, Margaret Urban's on this call as well, the Strong Families Nurse Home Visiting Program lead. She shared with me some of like with the language around how to talk about it too. It doesn't have to be a paragraph in a book, right? It just, she said, many people use substances such as drugs, alcohol, and tobacco at least some of the time in their life. Like just a statement, like a simple statement, and then you can do your screening. But just setting that stage of like a little bit of normalizing and yeah. And Margaret, I don't know if you have anything to share from the nursing visiting program about this as well, if you want to join in, but.
I'm not sure I have anything to add, but thank you so much. Yeah, I think the normalizing piece is key to a lot of our screening.
Awesome. Well, thank you all for taking time to join us today. Thanks to Marge, and special thanks to Katie to joining us with a different hat on today. Really appreciate all that you do. Um, and if anyone has any other follow-ups you think about after the fact, please don't be afraid to reach out. We definitely want to help people feel comfortable in this space. So if there's other resources you need or clarification, then please let us know how we can help. But we hope to see you next month on the 17th. We will doing our next webinar on caring for cardiac conditions in pregnancy. So shifting the clinical focus a little bit away from SUD for the next one, to make sure we're hitting all our different audiences and what they're working on in the clinical realm. But thank you all, and we hope to see you next time. Have a good day.